Again, my name is Michael Stewart. I work with the OI Foundation. If you have any questions, please put them into the chat feature below. Oh, you know what? I'm going to put into the send chat to everyone. So we're going to get started pretty soon. And what I'd like to do is, sorry, this is what happens when you multitask and type at the same time. So I'm going to get started pretty soon with today's session. If you have questions about orthopedic treatments or orthopedic perspectives on OI during the COVID-19 pandemic, please put it into the chat feature below. I am going to introduce now Tracy Hart, who is going to get us started for today. Thank you.
Great. Thanks, Michael. Hi, everyone. For those of you who don't know me, this is Tracy Hart. I'm the CEO of the Osteogenesis Imperfecta Foundation, and welcome here this afternoon to our session, which is titled, as Michael said, Orthopedic Perspectives on OI During the COVID-19 Pandemic with OI Experts. This is a challenging time for all of us, and we hope that by bringing you some of these sessions on various topics that it keeps us connected and that we can see what kinds of questions people have so we can keep bringing you information as we all get through this really challenging time together. So from there, I have the great pleasure of introducing our three speakers today. Just as a reminder for everyone, this is not telemedicine. This is an informational session, which our experts, they're all orthopedic surgeons, will be able to give you information. They're not COVID-19 experts, but they're experts in their field. So with that, I'd like to introduce our three speakers. First is Dr. Jeanne Flanagan with Children's Healthcare of Atlanta. We also have Dr. Jeanne Franzone with Nemours AI duPont Hospital for Children in Wilmington, Delaware, and Dr. Maegen Wallace from Children's Hospital and Medical Center in Omaha. And with that, I'd like to turn it over to Dr. Franzone, who will tell us a little bit more about herself and pass it on to our colleagues from there. So thanks, everyone. Dr. Franzone?
Thank you very much. Thank you, Michael. Thank you, Tracy. And thank you really to everyone at OIF for all the countless hours that you've been putting in to serve the OI community during this challenging time and always. My name is Jeanne Franzone. I'm part of the multidisciplinary OI team at the Nemours Alfred I duPont Hospital for Children in Wilmington, Delaware. Our clinic and team provides care on a multidisciplinary level from the prenatal period through delivery and up through the age of 35 years old. I'll start with a few basics of what our institution has done and is doing to address these challenging times, and then turn it over to Jill and Megan, and then we'll go from there. You know, these certainly are uncertain times, challenging times, and the logistics of orthopedic care looks very different today than it usually does. But one important message is the principles of care have not changed, nor has our availability and commitment to guiding all of our OI patients and families through this different time period. Our institution, like many, has implemented really a multitude of changes in keeping with both national guidelines as well as local guidelines. This ranges from screening patients prior to visits. There's a screening process at the door entering the hospital. There are some new restrictions on visitors to the hospital and who can accompany each patient to a visit. There's been a real push on our part to use more and more telemedicine as well as video conferences, just like this one. And our clinic spaces have changed with a goal of reducing exposure, and our day-to-day workflow has changed as we have certain teams in the hospital at any given time. So we'll certainly touch on many more of these details as we go on with this webinar, such as, you know, fracture care and surgeries and planning for a trip to the hospital. But again, something we'll also discuss is that our role as being available to all of our OI patients and really helping guide you through this different care pattern that is unchanged.
Thank you so much. Dr. Wallace, would you like to go next?
Sure, I'll go next. So just like Dr. Franzone described, we've done a lot of changes just to our regular workflow and also to how patients are getting into our facility. Screening calls are being done ahead of time so that patients that have symptoms are not brought in electively to the clinic to help protect other patients and us as healthcare workers as well. And then we've been decreasing exponentially the number of patients that we typically see in clinic, just overall in our general orthopedic clinic. And to help protect ourselves, but also to continue to be able to provide care to patients that need it, we've made teams of providers and nurses who are only working together during clinic so that if one of us gets infected, we're not infecting every single coworker that we work with. So we've just been strategic and kind of changing some of those typical workflows that we do. And then in terms of surgeries, and I know we'll touch on this a little bit more as we go on, but we have gotten to a point where we're only doing surgeries that over the next few weeks that we feel like are really necessary, just because we know here in Nebraska we don't have as many cases as other places on the coast, but we know that in the next few weeks that surge is going to happen, and so we're just trying to preserve some of our personal protective equipment supplies, ventilators, ICU beds, things that we know we're going to be needing in the next few weeks, just as we're preparing for what's coming.
Thank you. And Dr. Flanagan.
So I'm Dr. Jill Flanagan. I'm a pediatric orthopedic surgeon at Children's Healthcare of Atlanta. We're a little bit different. We're pretty spread out. We have all of our clinics are done in an outpatient setting, which is not in the hospital. So I'll touch base a little bit on what our changes are, which are pretty drastic. And then we have the inpatient setting. So for outpatient clinics, we before had 13 separate locations, essentially all across North Georgia. Now we only have open 5 clinics, and in those 5 clinics, there's 1 provider a day, really just to see anything on an emergency basis or patients right after surgery. We have 4 to 5 of those, again, sites open a day, and those are our busiest sites. Each physician rotates every 2 weeks, so I haven't honestly been in the office in a week. So I'm a stay-at-home mom, just like a lot of people are now. We are in groups, so there's a different group this week, and then I'm in the group that works next week. But just because I'm not in the office does not mean I'm not working, so I'm certainly available to answer questions, and we'll talk about that. Our patients are screened at the door before they get into the office with questions, travel, and their temperatures are taken as well. If a patient is sick, though, we still see them and we mask them, especially if it's needed on an urgent basis. We allow 1 visitor at this point with every child. So if there's 2 parents that come, we're only trying to bring 1 parent back. This is in effect for us at least until April 10th, and I'm not sure if it'll be longer than that, but I suspect that it may. For us, telehealth is coming soon. We are certainly working on that, and hopefully it'll be up and running in another week or so. On our inpatient side, we have canceled all elective surgeries, and I know there's been some questions coming in, and we'll touch base on what we define as elective versus not. And then I asked Dr. Lochner to be here as well because I figured there may be some questions about infusions, but as of right now in Atlanta, we are trying to limit our infusions to those at the highest risk, so our more moderate to severe OI patients and those with active bone pain. That's it.
Great, thank you so much. Before I move on, so you guys all sort of have already begun or pretty thoroughly answered my first question for all of you, which is, what is your institution doing in response to the coronavirus? And how does that impact patients and families? Before I move on to the next set of questions, is there anything else either of you or any of you would want to add? Cool. So I'm going to go on to a bunch of individual questions for each specific doctor. And if you guys want to add anything on to your colleagues, feel free to. So the first question is for Dr. Franzone. We've been talking a lot about elective surgeries and how, or you've been hearing about in the news, elective surgeries are being canceled across the country, not just for patients with OI, but everyone. For people with OI, what is an example of an elective surgery, and are those now being canceled or rescheduled for our community members?
Yeah, thank you, Michael. That's a great question, and one that we know is forefront in the thoughts of many of our OI patients and families. A very important question. The way I would think about that is, you know, the word elective is actually a difficult word. And in some instances can even be a little bit misleading, because we certainly don't elect for rods to bend and break. We don't elect for scoliosis to progress to the point that a surgery is needed, or elect for basilar invagination to become symptomatic. Those are all tough to think of in terms of a word like elective. A different way to think about surgeries would be in terms of the level of urgency. Will the outcome of the surgery be affected by waiting a certain period of time? And, you know, there certainly are urgent cases that, despite these environments, must go on. You know, the rare instance of an open fracture, or certain severely displaced fractures, or, you know, certainly other instances. But in each case, we have to balance the risks of coming into a hospital environment during this time period. And as Maegen touched on as well, the hospital equipment and supplies, protective equipment, ventilators. So I think that really brings us to the point that these decisions are absolutely case by case. And, you know, the other thing to rest assured about is we certainly don't take these decisions lightly. We know patients and families are oftentimes eager to, you know, have the surgeries done. And we are eager as orthopedic surgeons to do them as well. So this is very case by case, and also not decisions that are made in a bubble. You know, at our institution, we have a big OI team, and these are decisions that we discuss as a team. For me, with my partners, Dr. Cruz, Dr. Shah, Dr. Bober leading our orthogenetics team, our physical therapist, Rini Donahoe, and even beyond that, with the respected leaders of our department, our hospital leaders who have an up-to-date pulse on this ever-changing COVID-19 situation. Because the other thing to keep in mind is, in the big picture, the surgical procedure itself is really only one small piece of the whole care picture for a patient. There's other things to keep in mind when we're planning on these surgeries: the access to post-operative care, the access to post-operative physical therapy, which can be really important for maximizing outcome. So these are tough decisions. These are, you know, case by case, and something that really we continue as a team to look at in the sense of the total care for each of our patients.
Great, thank you so much. So next I want to go to, I have a question for Dr. Flanagan. What are some ways that you are making yourself available for your patients?
Okay. Yep, that's a good question. First, I'd like to second what Dr. Franzone said. It was perfect. You know, for OI, I don't think there's really any elective case. It's a matter of timing and when we do it. And I just want to keep that in mind. And I think you also asked if we are canceling surgeries. I know I certainly have on some of my OI patients. But I know, again, is the timing going to affect the long-term outcome? And if the answer is no, then we certainly wait. And pain is important too. So I've reached out to each of these families and asked, how is your child doing? Are they in any immediate pain at this time? Because that's obviously really important to us. And if the answers are no, then again, I don't want to risk the children coming into the hospital and getting exposed either. So again, always about risks and benefits. For families to get in touch with probably all of us that are here, As you can see, we're pretty readily accessible. We are here to help serve the OI community. Most of my patients have my personal email address, or I guess my work email address. I have a surgical scheduler, a patient care coordinator, and most of them know her direct phone number, her email address. There's some patients that have my cell phone, and we can certainly talk offline, but there are certainly barriers that I try to keep with myself and my patients. So I'm not saying I'm giving out my phone number to everybody. It's not because I don't like you. It's just I certainly try to keep my distance in a professional manner.
We understand.
Okay. All three of the surgeons that are here, I believe we all use Epic, and there is MyChart, which is the portal way to get a hold of us. I personally don't like it, but it is, again, a way to get a hold of us if you don't have an email. Again, as I alluded to, telemedicine is coming to us soon. I imagine Dr. Franzone already has it because their institution's well known for telemedicine. And then the last case, if you can't get in touch with us that way, reach out to the OI Foundation. They know all of us and they know how to get a hold of us. So that would be my last recommendation.
Thank you. And actually on that note, I'll be displaying our contact information later on. But if you have further questions for any of these doctors and want to reach out to them, if you contact us, we can get in contact with them on your behalf. Thank you so much, Dr. Flanagan.
Mm-hmm.
So finally, I want to ask Dr. Wallace a question. So what should you do if you think you have a fracture now?
That's a great question. So you all living with OI and having children or loved ones with OI, you experience these fractures. And so I think for a lot of our families and patients, it doesn't really change what you do or how you kind of manage fractures. Lots of our families and patients, if they suspect a fracture, are splinting at home. I think this is a time where you want to try and keep your loved ones out of the hospital unless it's an emergency. So obvious fractures where you're having a lot of pain, you can't splint and use medications at home to keep your loved one comfortable. I think that's a time when you consider going into the hospital. I know lots of families will elect to splint and then maybe call their doctor in the morning or that day, and maybe even get creative in how you get an x-ray. So maybe don't go to the hospital to get the x-ray. Maybe if you feel like you need an x-ray, try and go to a local x-ray radiology center, get an x-ray and have it sent. Just trying to increase that social distancing and decrease the amount of people that you come in contact with. Obviously, there's certain fractures, displaced femur fractures, they hurt a lot. Those of you that have experienced them or have loved ones that have. And so those times are times where, you don't really have an option other than go to the hospital. But I think having splint materials at home is really important for you. And then if you have splinted in the past, then you know how to do that. But if you don't, then just getting some more information. I wouldn't recommend practicing splinting because you don't want to use your supplies if you don't really need them. But watching videos and learning how to do splinting at home is really important, just to keep your loved ones or your children comfortable. There's a couple of videos that I think the OI staff will be able to post when they post this talk that show examples of how to do some upper extremity splinting and some lower extremity splinting. Obviously, knowing if you have a rod in place. I think everyone that has rods know that your fractures tend to hurt a little bit less when you have a rod than when you don't. So if the extremity isn't significantly deformed and you can be comfortable splinted and doing some medication at home, then maybe you can delay when you need to go in, or even if you need to go in to get an x-ray in the next few weeks and try and get further down the road with this pandemic to try and decrease your exposure risk.
Great, thank you so much. So now we are done with our pre-selected questions, and already I see many questions from our attendees. We appreciate these. So I'm going to start off with just going in order in which we receive them. Again, I just want to clarify that this is not telemedicine, so unfortunately we cannot give very specific recommendations to individual people on their exact procedures, but we can provide the best, most up-to-date information we can. So here's a question. Would a rod revision procedure without a fracture be medically necessary or elective?
I think that's a loaded question. It depends on why the rod's being revised. I think if a rod's in place, you know that, you know, in the next few months, you're probably going to be thinking about having the rod revised. I would consider waiting until after the peak of this pandemic just to decrease your risk. Right now, yeah, at least in my hospital, a case like that, if I scheduled that, cases that are getting booked that are new, that weren't scheduled before, are actually going to a committee to get approved to get scheduled. So a case like that likely wouldn't get approved to get scheduled. Obviously, if there was a fracture and a bent rod and pain was not controlled, that's a different scenario.
Yeah, I would second that. Very similar, you know, process, but again, something really case by case to discuss with your surgeon, and, you know, ideally discuss over the phone or in such a way that doesn't bring you into an exposed environment. And it really depends on so many factors.
Absolutely.
Great, thank you all so much. Another question. So this is a slightly longer question. So I'm going to read off it sentence by sentence, and if at some point you want to jump in, go for it. So I have a question about options for intubation if that is necessary at some point. I have OI and have had a cervical slip as a result of a troubled intubation during a recent surgery. This slip is significant and interferes with breathing, etc. at times. What are other options OI patients can have instead of regular intubation if symptoms of COVID-19 require it?
Sure. I'll tackle that one. I think what's most important, again, is to decide the timing of the surgery. So trouble breathing obviously is a concern. When we think about cervical disc herniations, the term we use is something called myelopathy. It's when the spinal cord itself is being pushed against, and that can have devastating results if not addressed at an early basis. As far as intubation, none of us are anesthesiologists, I don't think, but there are definitely other ways to do safer intubations for patients just in general. So there's fiber optic intubation, so they're using special tools to intubate, so you're not moving the neck. There's even nasal intubation where you go in through the nose. I have seen some OI patients that have what we call occipital cervical fusions, so that the head is fused to the neck, so the neck does not move. I'm not necessarily suggesting for this person, but there are some that may need tracheostomies in order to be intubated as well. So yes, there are other ways to intubate. And again, the answer I'd have for this person is it really depends upon the timing. If it's something that can wait and the symptoms are mild, that's certainly a discussion they should have with their neurosurgeon, I'm assuming, or orthopedic surgeon for their neck. But yes, there are other ways to safely intubate.
Great, thank you so much. So I want to ask a question here that says, is there a way to reduce rib fractures with a cough?
If you discover one, share it with everyone, please.
Okay. So I'm taking that as we don't know.
Not aware. But if you discover something that works, I think everyone would like to know.
So I want to move on to our next set of questions. So what is the thought about having PTs coming into the house? I'm at the 6-month mark from a very bad break with surgery and finally got weight bearing. Vital to fight atrophy, but is it too much of a risk?
Yeah, that's a very timely question, and one that gets back to, you know, the importance of the overall care, and that may depend a little bit locally, but I think we would, you know, all agree with you on the importance of weight bearing and building the muscle strength to help the bone strengthen and help the overall recovery. You know, whether it's safer to travel to a physical therapy place or have, bring somebody who could have been exposed into the home. That's a little bit of a risk-benefit analysis that may depend on a local level as well, and a frank discussion of, ways to really minimize exposure and keep that social distance. If there are ways to do that and perhaps, do it over a telemedicine or work on exercises in such a way to really to have that guidance, but minimize exposure, I would say, in general would be the principles to think about.
Great, thank you. This next question, I apologize. I'm not sure if I don't understand a term or maybe there's a typo. We're all human here, so I apologize, but I'm gonna read it anyway. And if you guys want further clarification, we're going to skip it temporarily and ask that questioner to clarify. This person says, my daughter has had surgery for a femur fracture. She got TENS. It was 10 days ago. The doctor is not able to check on her because we're all in social isolation. What happens if if 3 weeks pass and there's no possibility of a checkup?
That's a great question. I actually just addressed something very similar with one of my patients yesterday. I think that in my opinion, if the surgical incisions are healing nicely and your pain is decreasing, it's not vital to get an x-ray right now, especially if you're in a high risk area. I think it's, I would lean more on the conservative side and wait until the peak of the pandemic in your area, and then consider going in and getting an x-ray. Obviously, if there are other concerns or pain isn't decreasing like you would anticipate, or if there are concerns of, around the sites of the incisions, then I think those are things you need to call and make contact with your surgeon about.
Yeah, I would echo that. That's something I think we all face on a daily basis now with our OI populations and folks who have had surgery over the past few weeks before this really surged. And again, we're trying to be as flexible as possible to, sometimes we can't do telemedicine. Sometimes it has to be a phone call and pictures. Sometimes it has to be a WebEx, but different ways. And we're trying to be as flexible as possible to, really try to get some follow-up in. And like you said, weigh the risks and benefits of when an x-ray is needed and where that happens.
Yeah, and luckily, as most of you guys know, people with OI don't have problems with healing, they just have problems breaking. So especially for femur, I don't remember a femur not healing. So tibias are a little bit different, but for femur at 3 weeks, pretty consistently is healed. And again, your child or your loved one's going to tell you when it feels better. And that, again, if we can't use an x-ray, that's certainly a guide that I think most of us would use. A 3-week mark would be when we definitely start taking splints off, test the leg a little bit and see. Testing at things in a tub may be best since if you can't get into a pool, just to see how it feels as well. But 3 weeks, again, the question was, how do we know if it's healing if we can't see callus? It's healing by the pain. Mm-hmm. So if they're still having pain at 3 weeks, that would definitely certainly reach out to us either way, or reach out to your actual surgeon. But I would say 3 weeks is pretty consistent for most patients in terms of healing.
Great, thank you so much. So I'm going to move on to some more. So this question is, I have an issue where a rod has migrated toward the left hip area. When I was younger, my rod migrated toward the knee and I had surgery. I'm not worried about the pain of putting off the surgery on my rod and my left femur. My concern is, as with my knee years ago, is potential damage of the rod to the hip area, not pain. I have rods, pins in various areas. Thank you.
So it sounds like the question is whether having a prominent rod up by the hip could cause additional damage. Is that?
That's it.
Yes. So it says, my concern is as with my knee years ago, about potential damage of the rod to the hip area. So will my rod damage my hip area?
Well, it's hard to know exactly what implants you have in, but if it's the typical style of rod that we use, if it's just backed out some, usually that doesn't cause, it causes pain for sure. But usually it's just irritation of the muscle, and it usually doesn't cause any issues with the hip joint itself, other than just being painful. But again, without knowing exactly what implants you have, that's a little bit hard to answer.
I'd agree. The knees are different because when the rod migrates, it goes into the joint and can cause cartilage damage. But the rods, most of them, if they migrate out, so especially the traditional Fossey-Duval rod, it very rarely, I haven't ever seen it go inside the hip joint to cause permanent issues. Again, certainly not ideal, but I don't anticipate that would cause permanent long-term issues to the hip joint itself.
Great, thank you. So the next two questions I see are not explicitly about ortho questions, but I think larger questions that some of us are thinking now. And so if you guys don't want to answer them, I think between Tracy and I, we can have an answer for this. So are people with OI considered high risk or immune compromised? And are they at a higher risk of suffering complications from COVID-19 than the general population?
I think this was actually really, really well covered in the session the other day with Dr. Glorio and Dr. Sandhouse, and I learned a lot during that session. I thought it was very helpful. But we do know taking care of the OI population, especially with the lung involvement with OI, that there are special considerations, and this is something that I know a lot of our patients are wondering as they're in and around various workforces. So it's certainly something that we're working with our patients on to minimize the risk. But I do think it was really well covered the other day.
Mm-hmm. Yes, and so I just want to make a quick plug again for the sessions that we did last week with Dr. Sandhouse and Dr. Glorio, covering specifically the complications around OI and having COVID-19, and how people with OI are at a higher risk for more severe symptoms.
Michael, maybe we can put the link up to that that session.
Yes, I will make that right now as we're talking. And I want to know, we have another question here that, again, sort of following this larger theme of not a specific explicitly an ortho concern, but I think related to some of the things we're thinking about today is what is the general consensus on traveling, be it by car, plane, boat, or out of state, out of country, and when do we think that this should be a consideration for us? I know from what I'm hearing, definitely, if it's non-essential, don't do it.
Right.
But I'm sure you guys can probably elaborate on that slightly.
Well, for us here in Omaha, most of our patients with OI actually travel to come and see us. So, and thinking about that, we've been pretty aggressive in canceling our clinics. I think that staying home is kind of what the CDC is recommending. And so I think that as providers, we need to follow those guidelines. And I think all of us in terms of travel, personally and for our patients, I think looking at whatever the CDC is recommending is really what we should be going by at this point.
And especially in a higher risk group.
Mm-hmm.
I mean, none of us are traveling right now, so I would not recommend any kind of travel for a high risk group until we're told otherwise.
Mm-hmm.
Also at the risk of being stuck somewhere that isn't, a comfortable place to be.
Absolutely. I just want to share, I'm going to be sharing my screen for just a brief moment with everyone. Just bear with me while I download this for all of us. That's not even the right word, I know, but. Okay, can you all see my PowerPoint slide open? Mm-hmm. Okay, I see some nodding heads. So just very, very quick for those of us joining the call, I want to let you all know that, so the OI Foundation, we are gathering all of our COVID-19 resources onto one page. If you go to oif.org, coronavirus 2019. All of our resources, all of our videos and related fact sheets for OI are going to be posted there. This is also linked directly to on our homepage, www.oif.org, as well as the video that we did with Dr. Sandhouse and Dr. Glory about pulmonary concerns with COVID-19. Also, if you want to reach out to the OIF directly, the best way to contact us is through the email bone link at oif.org. We are all working remotely, as you can see by my living room behind me. So our phone lines are also open and you can leave us a message, but I think the best way to reach us right now is through email. If you email us at bonelink@oif.org, we will then redirect you to the right person. Also, if you want to get in contact with one of the doctors speaking here today, I'm sure they'll be happy to answer more questions as well as they become available. Do we have any other questions? I'm going to stop my share now. Do we have any other questions from the audience? Before we move on, I want to actually then bring it back to Dr. Flanagan, Wallace, and Dr. Franzone. Do you guys have any final words for our audience here today that you would give to them now?
Hey, Michael, this is Tracy. Can I ask a quick question
sure.
of all three? Are your institutions still doing infusions or no?
So that's a good question. I don't know if Dr. Lochner's online. So she's does the infusions for us in Atlanta, and I've been communicating with her daily.
I'm here if you want, Jill.
Okay. You can answer that for us.
So it's been tricky, obviously, in terms of admissions in general have been made, like everyone's saying, just like surgeries, elective admissions have been canceled. It's been somewhat open-ended in terms of what's considered elective, as you've been discussing in terms of surgeries. I've been taking a very similar approach that in the very young, more severe OI, where we know it will have a change in fracture rate, and babies will be in pain and may not be able to tell us, et cetera. The infants are pretty much getting their infusions on time. If I have older kids who actually have, chronic pain and it does make a clear difference to have the infusion, they are, with discussion or opting to or not have infusions. So typically we have 20 to 30 infusions a month. We're probably having 10 this month. So it is a significant decrease, but I'm trying to permit it for the kids who, the parents or the kids are really asking for them. And we are doing it in an outpatient setting with all the distance kind of guidelines, limited provider contact, et cetera, to try to minimize, risk during the infusion. So you get your infusion, you go home, you don't stay overnight.
Yeah, that's a great question. And I would echo that from our institution as well. Dr. Bober is our orthogeneticist, and along with his team has been, as you mentioned, guiding patients on a case-by-case basis, really taking on, not an all or none, but how do we, continue the medication that really affects quality of life and patient well-being, while also minimizing the risk. For folks on something like Zometa, if they had a dose fairly recently, they might not need another one until the crisis is done. For folks on pamidronate, a little bit different. And for our patients who might have been in for a 3-day infusion, Dr. Bober's cutting that back to 1 day. Certainly policies in place to really minimize exposure and risk while in the hospital. Other patients receive their infusions at home, and this, gets back to the question we talked about earlier, but that's a little bit less of, a risk in terms of coming to the hospital. But really, again, a case-by-case basis, and not an all or none.
Great.
Yeah, we're very similar right now. If we have patients coming to the hospital for infusions or just getting them done in our infusion center, that's what we typically do. And so those are still going as of today. That might change. And then a lot of our patients have either a hospital they go to locally, or we have quite a few patients that do home infusions. And so, but I think it's definitely a case by case. And a lot of our patients have been a little nervous because, you know, their prescription for their infusion expires after a year. That patients shouldn't be nervous about that. Regardless, we know we're having to cancel clinics and patients aren't able to get in for their yearly appointments. So we're going to be renewing those prescriptions like they were here for clinic, and then adjusting doses the next time they're able to come to clinic whenever it's safe to travel and come to the hospital again.
And I think that brings up another really good point. We've, you know, focused a lot on surgeries and fractures, but, you know, not forgetting all the non-surgical principles that keep us all healthy. You know, remembering amidst all this craziness, you know, the vitamin D intake is still really important. Appropriate calcium intake. You know, mental health is critically important, and there was a great session about that earlier in the day. You know, despite changing, you know, local facilities and environments, you know, maintaining an exercise regimen to keep muscles strong and keep bones strong, you know, amidst all this craziness, as much as we can, not lose sight of the fact that all those things are just really vitally important as well.
Great, thank you so much. So actually we have a few more questions now. I jumped the gun before. So now we have, how safe are cervical fusions for OI patients?
I can talk about that one again, since I talked about it before.
Mm-hmm.
And again, I think it's a question that you need to ask your surgeon themselves. I mean, if the surgery is indicated for a good reason, then yeah, I mean, you always have to analyze what are the risks of surgery, what are the benefits of surgery, whether you have OI or not. And so if this person is myelopathic, where the disc is compressing on the spinal cord, that's a bad problem. And so the risk of cervical fusion is probably pretty minimal compared to the potential benefit. So again, I think it just goes back to talking to their specific doctor about that. You know, there are certainly some special considerations for OI and cervical fusions. I'd be thinking more the intubation process, anything else. But again, OI people heal their bones just fine. So I would imagine if a cervical fusion was done, that they would heal just like anybody else. Whether that puts more stress on the head, having a larger head, and having ligamentous laxity, I really can't answer that. I don't know if either of you guys can do that. I don't know if there's been any specific research that's been done.
Yeah, and I think, yeah, those are great points. And, you know, also, like you said, a discussion with your surgeon is, you know, the benefits of a surgeon who sees, you know, more OI in terms of the special considerations, and also, you know, the full care team in the OR, because the anesthesiology, the positioning, you know, there's so many pieces of a surgery like that, you know, that, you know, OI plays a role at every step along the way, and, you know, ensuring comfort level in that regard is important.
Great, thank you. So now this last question we have here is, and this was sort of addressed before, and this person I think I don't know the answer, but I've heard that people with OI tend to have respiratory issues. I believe more severe types of OI are at a greater risk, but what about people with type 1 with a barrel chest? How might COVID-19 affect this? So again, I think the answer is please check out the video with Dr. Sandhouse, but unless any of you would want to jump in as well.
No, they're the pulmonary experts, and I think they addressed it very nicely.
Okay. Yeah. And I see some of my colleagues have put in video links into the chat feature as well, which will get you to that information. But we just want to, while you're here, we want to address as many of these questions as we can.
Absolutely.
So does anyone have any other questions? You're welcome. So now I think if the doctors who are so graciously lent us their time today, if you have any other final things that you'd like to say to the people on the call, the people watching this, we would love to give you the floor.
I'll go ahead and say, you know, ending on a realistic but also a positive note, you know, these are unpredictable times. These are challenging times. This is a new environment for us as orthopedic surgeons as well. But I think, you know, now, even more than ever, is a time that we do need to rely on our communities. We're extremely fortunate to have you as the OIF, the anchor of, you know, our community here. And, you know, rest assured that even though the face of healthcare is different these days, that, like we've touched on, our availability, you know, remains the same. Our commitment to the OI community and really helping you navigate this daily changing process. And that, you know, I would end with by supporting each other is how we'll get through these times.
Yeah, I agree. And I think, you know, definitely reaching out if you have questions. I think, you know, calling your surgeon or your OI provider before going to the hospital, I think is important. And then also being patient with us, because every day things are changing, and one day we're told we can do semi-urgent cases and the next day we're told we can only do emergencies. So it's every day is changing and every location around the country is different. And so just being patient with us and just know that we're here. We want to continue to provide care for you. It's frustrating for us as well when we can't provide the services that we know that you need. So just supporting each other, and eventually we'll all be able to, you know, hopefully get back to business as usual. But for now, this is our current reality.
Yep. And then lastly too, I want to thank the OI Foundation. I mean, what you guys have done just in this last week of putting all this together is pretty incredible. And again, it just shows your guys' dedication to all these people around the world that I'm seeing that are reaching in. I think in some ways I'm more accessible than I used to be. So, you know, please feel free to reach out. And I'll just leave you with this. It's a message I teach my residents. It's, if you think you're supposed to call me, the answer is you're supposed to call me. So if you have any doubts about something, reach out to us and we're certainly here to help out.
Thank you all so much. I love that as a ending note. So again, if you want to contact the OIF, the best way to get in contact with us is through our email, phonelink@oif.org. And we're going to try to get back to you as soon as we can. And thank you all so much. Stay healthy, and we're going to try to get more of these resources out to you as well. But as you all know, this is a evolving situation, so we will let you. We basically let you know as soon as these things are organized, and we're going to keep doing that. Thank you all so much, and have a great day.
Thanks, everyone.
Thank you.
Thank you.
Okay, bye.